Yeah. So the Haudenosaunee, the Wendat, the Mississauga of the Credit, and the Anishinaabe.
Thank you. I just wanted to bring them into the space since we are on that land, and that's the space that we need to honor. I come to you from the traditional and ancestral homelands of the Musqueam, Tsleil-Waututh, and Squamish nations of what's now known as Western Canada. This is all Turtle Island, and I just want to ground us first in that acknowledgement, because there's so much we can learn from the way birth was done and curated and spaces, that the importance of the land and grounding yourself there. I grew up in the first South Asian family to arrive in the traditional and stolen lands of the Susquehanna nations in what's now known as Pennsylvania in the United States. And I've been in continuous practice for 40 years, first as a registered midwife in the US and then the last 18 years here in Canada. Along the way, as you heard, I've done education, quality improvement, and research. But most importantly for today, I will say I'm the parent of 4 young women. And I don't know why I'm emotional, but I'll tell you later about why there's a big thing going on in my family now. But one of my daughters recently had labor and birth herself a year ago. And over my life, I've experienced both privilege and exclusion in education, housing, personal safety, the impact of discriminatory legal systems, incarceration, untimely loss, race-based and profession-based discrimination and privilege. And all of that informs the questions I ask, the approaches I use for my research and practice. And that's what I'm going to really talk to you also about, what maybe we can bring into that in the work that you do. I'm, of course, grateful to the funders that have supported the studies I've done and I'm going to tell you about today. And grateful for the invitation. I'm going to start by saying that there are some assumptions that I'm going to start with. I can see from last night in the incredible exhibit that I don't have to really talk about our shared goal of reducing unnecessary interventions. And I won't get into any debates about the global context of risk and reason. We have a global set of designers and architects here, and context matters, and where we are matters. But to me, there are some common denominators that we can talk about. And I'm also not going to talk about the comparative effectiveness of different pain management or techniques to speed up labor. You all know those things. And I'm not really coming from the philosophy that natural is better. It's more about what we know, both from ancestral knowledge and from modern science, about what's most effective and what's most kind. And then again, I am a birthplace researcher, but today I'm going to not talk to you about safety and efficacy, except what's obvious through what people are telling us. So you're all familiar with this image, right? When this is the DNA, right? The double helix. It's when the characteristics of 2 humans join, and that the way those characteristics join may predict the physiology of a new human being. And it's a pair of helices intertwined around a common axis or a common agenda. So today I want to talk to you about what this image tells us about how an environment is interlaced with the physiology of human physiology and how it can affect the course of the labor, and that if we can respect and honor and pay attention to that and individualize the care, the environment to that person, then we're more likely to achieve what that person wants. I'm not going to talk to you a lot about oxytocin and noradrenaline, and I know many of you know about that, and we have one of the world's experts in that about its interface with environment. She's going to speak to you tomorrow, I think. So I will move on, but I will start with that sort of shared definition of what is a physiologic birth. And so for today, we'll use this definition, which says a normal physiologic labor and birth is one that's powered by the innate human capacity of the pregnant person and family. In 2016, the WHO and that's now almost a decade, right? So about a decade ago, finally, where we had been talking a lot about quality and safety globally, and particularly in the Global South, we had been talking about things like clean water and access to surgical services and access to skilled birth providers and functioning referral systems. But we really hadn't been attending to the impact of experience. And in fact, when I go to India, the homelands where my family came from, you'll still hear many physicians say, yes, well, respectful care is important. It's important to be nice to people, but they don't really get the connection between respectful environments or respectful care and physiology or in outcomes. It's been a decade now that that's been acknowledged. And of course, we didn't have measures and we didn't have ways to show those connections. Now I'm going to tell you about how we're beginning to be able to do that. So the four that are in red there, functioning referral systems, respect and preservation of dignity, emotional support, and the available essential physical resources are the ones that I think that are most relevant to you. But these are high level of recommendations. And so why speak about experience of birth space when we're addressing morbidity and mortality? Those are major things that really are not even across the world. But I think when you realize that we've been measuring all these other things like hand washing and clean and medications to stop bleeding, and we haven't been measuring or understanding the impact of disrespect or abuse, and certainly haven't been doing it around historically oppressed communities who have the worst outcomes. So let's talk about measurement. Let's talk about asking different questions. So this is a beautiful framework that was published after the Lancet. There were 3 Lancet series, one on maternal mortality and health, one on midwifery, and one on reducing cesareans, and with the goal of reducing unnecessary C-sections. All of them agreed that midwifery was the solution and that we weren't really looking at the right things. But if you look at this, everything that's inside the box, except for the pink ones off to the right, the first line management of medical complications of birth is what 90% of the research dollars have gone into. And that's for 10% of the populations, right? 10% of the people have been taking 90% and all of these other things that are on your screen about organization of care, about the values of philosophy, care practices, the birth environment, the structure, the infrastructure, how we teach, none of that has really been attended to as a strategy to improve outcomes. So let's talk about how we ask the right questions in the right way, ask the right people, and then we can talk about asking enough people. A lot of people say a lot of things about small studies and qualitative and the voices of people, and they don't believe it unless you have thousands of people. So I'm going to talk to you about what happens when you ask thousands of people. My lab conducts health services and participatory action research with a focus on experience of perinatal care among communities who experience the most adverse outcomes in North America, although, as you heard, these tools are now being used in many, many countries. For the purposes of the studies, the outcomes I'm going to tell you about today, what we've found are from people in North America with a centering the voices of First Nations, Métis, and Inuit people, Black and Brown communities, those who identify as Two-Spirit, LGBTQ plus, trans and queer people who are recent immigrants, newcomers, people who live with disabilities, or who live with other challenges like substance use or housing instability or incarceration. The first community-based participatory research study we did was in the province of British Columbia. We did have, as you can see, responses from all over the province. It's a very big province. For those of you who come from Europe, it's, to go from the top of British Columbia to the bottom of British Columbia in Vancouver, where I live, is as far as from Canada to Mexico. So it's a very landmass, huge, and some tough terrain, mountainous places where there are no roads, and people live throughout that, as you can see that. So we had about, we had 4,000 responses, but for completed surveys, we had 2,051 with reporting on, they could report on more than one bird, so 3,400 care experiences. In the US, we worked with communities of color with the help of health workers and community agencies that supported communities of color. And we did a large national study and got responses from all across, in all 50 states, as you can see. And then the more recent, the one that we've just completed about a year ago, it took a year. It's a complex study with many domains, and I'm just going to try and focus on the things that are relevant to you around what the people told us about birth space today. But we did get 6,096 responses from across Canada, again, as you can see, from all provinces and territories. We knew that in Canada we have 600 different First Nations, and so we knew we did not have the capacity to authentically build a relationship with each of those nations, understand their context, understand what was most important to them. So we started in BC, where I live, where we had relationships. We had Indigenous researchers who could lead the way. We worked in 5 communities. Some of them actually used our measures, and some of them did storytelling and other ways of understanding this concept of research. I also want to say, while we did intentionally, in our co-creation of our data collection tool for Respect, we did have some wonderful queer and trans researchers who helped us, and people with lived experience to ask the questions in the right way. But it wasn't enough, really, because as you may know, that there are many different sexual and gender minoritized identities, and the non-gestational parent is also important to that story of respect. So now one of my colleagues who is leading the way, who has lived experience, actually 2 of my colleagues, Molly Altman and AJ Loic, have launched the Birth Includes Us study, which has taken our measures and our survey instruments and adapted it to those populations. So that is also informing this process. So the way we start always is to start with a steering council of service users, or whoever. If we're studying midwives, we start with a steering council of midwives. If we're studying people who give birth, we have them. And if we're trying to focus on marginalized identities, then the steering council is representative. And then, of course, we know we have to have this transdisciplinary approach, right? We have to have the service providers, the health workers. We have to have people from public health, from people who can actually make a difference. So we had a really multidisciplinary team that was sort of behind, following the lead of the steering council. It was an iterative process where we would co-create something or decide, how are we going to start, what are the topics that we're going to study, where the community would decide the topics, and then we would try and find those measures, and if we didn't have them, then we would go and co-create those measures with the community. So it takes longer when you do research that way, but it's so satisfying. And then now we're in that process of unpacking the data, and the analysis and interpretation is led by those culture-matched and underrepresented scholars. So that's what we mean by integrated continuous knowledge translation. People sometimes, when I study about respect, I've been a midwife, as I told you, for 40 years, and I'm like, why am I still talking about this? And why do I have to prove that, breast is best, or that, respect is core? And then I realized that it's because it's my lived experience, and it's not most people's lived experience. And what's exciting is that we now have different ways to make those data come alive. So in all of these studies, as I said, the community decides what to study, what questions to ask, how to ask them, who to ask the questions of, how are the best ways to engage their communities, and then they decide on the key messages and how to tell the story, and we always get permission. So to come here, I went back to my steering council and I said, this group wants to hear it. And they said, of course you have to talk to the designers and architects, because that's where it starts, our birth environment. So I'm here with their permission. Respect study, the images, it was really important for us to have, at least important for the steering council to say that when we did our data collection even, and distributed, we needed inclusive images. People needed to see themselves. And so as I go through the various things that we did, I want you just to be thinking about, I went to the beautiful exhibit yesterday, and I saw many beautiful spaces, but what I didn't see was myself. And in Canada, you know, there's a large South Asian population, and I'll tell you they're everywhere in the world. So are we thinking about what we think is beautiful or feels home-like, or are we thinking about the people who use those spaces? I saw one that was like that, the one from Uganda. Where was it? It was, sorry? Yes. Where is that? Kambuchala. Beautiful, beautiful, and that seemed very congruent with the people who give birth there, right? So just keep thinking about these things. So we also were very intentional about when we didn't intend it for it to be just a survey. We wanted to collect the data where people got care, you know, and have data doulas from their communities who could, if they didn't have access to internet or you know, knew how to do an online survey, that people could mentor them through that. But we were ready to launch after 2 years of developing these tools and measures and gathering them. We were ready to launch in April of 2020. So we had to completely stop and change everything, and it took us a few months to make everything to be online data collection, and I'm so grateful. We had 18 regional recruitment coordinators from across the country who just sort of emerged and said, this research has to go on, we will help, and so we turned it into an online survey, and we knew that we were asking people who were busy and who had sometimes, and who were experiencing the George Floyd's murder and the discovery of unmarked graves and all these very traumatizing things. And so we had to make it easy for them. So they could come in and come out, they could do it on their phone, they could do it in their language, they could do it over time. We left it open for them. They could come back to the survey, and we were transparent about how long it would take, and that they could skip questions if they felt hard to them. We had done a 2-year process of trying to find out what does respect mean to the people in Canada. That's who we were studying. And we went around the world because respectful care has been studied so many places, but not really in a survey in a large quantitative way, more in focus groups and in small conversations. So we took those focus group prompts and turned them into survey questions, and then went to our palette testers and said, does this make sense to you? This is how you would say it. Is this, and amazing, they said, you need to say it in first person. Not did someone, introduce themselves to you, but, in my birth, somebody shouted at me. It was make it sound like they're telling their story, and that's what it's research examining the stories of pregnancy and childbirth in Canada today. That's respect. It took us 2 months to come up with a title that was acceptable to the Steering Council and accessible. So let's look at what happens when you use these person-centered measures of quality of care and how it looks different. All of you know, I know you're not health researchers, but for those of you who are clinicians, you will know that we usually talk about SES, socioeconomic status, right? And the classic way to understand SES and its impact on outcomes is to look at household size and income. So you ask someone, how much do you make and how many people live in your house? And that doesn't take into account the other people you support in your community. They may not be in your house. It does not take into account whether the electricity was turned off at the extra month, whether you needed a housing subsidy, whether or not you received assistance, or you had enough money to buy food at the end of the month, or at all. Or if you go to some Indigenous communities in Canada and you go to the grocery store, the shelves are pretty much empty and there is no fresh food that they can access, right? So they said you need to ask the question in a different way. And they also said, people always ask us, did you need safe house or counseling or help to quit smoking or mental health assistance? But nobody asks us, did someone help us get it? And this slide shows you the gap between identified need and the assistance they got. There are not even any orange bars on some of those, right? We're doing pretty well with smoking cessation, and that's about the only one where there isn't a gap between. And when you disaggregate it by race, it's this slide just says there's 2 to 3 times more unmet need among Black and Indigenous communities in Canada. And when they said, you can't just ask also what about what helps us survive, succeed, and thrive? What about that salutogenic approach? And when we asked them that, you can see it wasn't the health system that was helping them, right? It was their family and their community, maybe their faith community. Again, decision-making, there's a lot about autonomy and decision-making. Well, when we asked people, how important was it for you to lead decisions? And this we've repeated in every country. We've been in many, many countries with this question. Over 90% always say, I want to lead the decisions about my body and my care. Only about 1% said it wasn't important. And about half, 47% of people said they wanted the input of their providers. But not everybody. But this is who's really making the decisions. Right? This is just for C-sections, and the green and the blue are all provider-led decisions. This is the mother's autonomy and decision-making scale. We call it the MADM scale. We have also changed the name to be My Autonomy and Decision-Making to be more gender inclusive, but this is how many people know of it because it's been around for a while. It is 7 statements that people can respond to with an agree or to disagree Likert scale, and those strongly disagree to strongly agree turn in on the back end to a number. So the range of scores is 7 to 42, and it's not any individual question, it's all of them together. That's measuring this concept of autonomy. When we have that score, then we can connect it to identity, plays, etc. So we know that autonomy scores by place of birth are very, very different, right? So if you have community birth and you have, or home birth, even when you have a community birth that's outside the hospital and you're in your home, there's a huge difference between people's lived experience of autonomy. And then it matters what your, for those of you who are taking, I'm happy to share slides, so but as you want. For these, the things are published already. I'll tell you when they're not published yet. In Canada and we consistently find that people's lived experience of autonomy is greater when they are attended by a midwife or another birth worker that may or may not be a midwife, but is from their community. And it goes, and it's less as you get into conventional care, which is where most people get their care. But less midwives get too complacent when we disaggregate it by race. Again, you will see, now this is a hard, and for those of you who are not used to looking at box plot, the bars indicate the range of responses. The small gray or black bar in the middle is the median, so that's the average response. And the orange are people who are Black, who self-identify as Black. And you can see it doesn't matter how much money they make, what their profession is, their autonomy stays low all the way through. And this is regardless of provider. Worse with midwives. I hope this will work. Is there a sound here? Should be, let's see. No. Oh, can't hear it. Mm-hmm. We can do it without her sound, but it makes such a difference when you hear them, actually.
We should be able to. There we go. Can I play it?
Yeah, go ahead, let's go back one so you get the whole thing. Oh, there you go.
I was dropped by my provider at 37 weeks pregnant because I refused the 4th glucose test. I took it anyway, and they sent me a firing note the day after. I had to ask them to take me back as a client since no other provider would help me, and they required me to sign something stating I would do whatever they asked of me.
I don't like being talked at. I'm an engineer. I need things that make sense. And I want choices to be explained to other women too.
These are actors, but they are culture matched and identity matched actors speaking the actual words that were given in our study. So we also have a different measure called the Mothers on Respect Index, or more respect. And in this shows you the back end, so they don't see the numbers and they don't, they just respond to the statements. But we are able then to turn it into a quantitative measure, and this is about how comfortable people feel asking questions, accepting options, declining options, whether or not they feel like someone is too rushed, or they hold back their questions because they have a difference of opinion, or if they feel like they were treated poorly because of something about their identity. And when we look at that, this is in Canada again, if you see the dotted line that goes across, if you think of that as the line of equity, where the level of care is the same for everyone, regardless of race, culture, background, then the further a dot is from this line, the greater the disparity. All right, so again, you'll see that compared to the majority, which in Canada is white, the Indigenous, First Nations, Métis, or Inuit people have 27% lower odds of being in the top 33% of the respect index, and 66% higher odds of being in the bottom of the respect index. People of color are also in that situation, people with disabilities, people with low income. This is a way of showing that actually, respect, all of these things, that it matters, and there are differences. The obstetrician who I saw was rude, pulled out his cell phone during my exam to play on it and show it off while standing below the area of my exposed vulva and vagina. It was the most humiliating, debasing exam I've ever been subjected to in my life. This Indigenous woman was 22 years old. That will stay with her for the rest of her life. I was bullied by the head nurse during my delivery. She turned my birth into a spectacle by bringing in multiple students and essentially made an example of me. To this day, I don't know why. I suspect she thought that things were not moving along quickly enough and decided she was going to show people how it was done. So now we get into the more egregious violations. So it's not just about autonomy and respect, it's also about human rights violations. A healthcare provider shouted at me, scolded me, shared my personal information without consent, ignored me, refused to help, failed to respond to my requests for help. I experienced physical abuse. Someone threatened me. When we looked in the US and in Canada, we found that those experiences, it was 1 out of 6 across the board, so 17% in the US, 50% in Canada. But when you look at Black and brown and marginalized communities, it was double. And it was the same as in the Global South. So in the same year, we both published 4 countries in the Global South and the United States of America, exactly the same levels of disability. So people think in high-resource countries, that happens there. There people are slapped and hit. It's happening. I'm just here to tell you, it's happening globally. It's a gendered form of, it's gender-based violence is what it is, what we're talking about. So 3 in 6 experienced mistreatment in Canada. I have not published this yet, and it's coming out. So what's linked to mistreatment? It's all the things you might expect, the things that I keep saying, whether you're an immigrant, whether you have low socioeconomic status. And sadly, if you have more risk factor, you have a higher risk thing, so you have all these beautiful birth spaces you're looking at, and what can we do for those people who are already experiencing a complex pregnancy or have lots of social risks. Are those spaces accessible to those communities? What about if someone has high BMI? We find that we looked at these relationships between BMI and, do you know what BMI is? People with obesity, who live with obesity. So they have some of the lowest levels of autonomy and decision-making, respect, non-consensual care, disparities in access, but are beds designed for this population? Are chairs and ways to move around? And how does that then contribute to weight stigma if we can't care for them in the same ways? The way they gave birth also affected their rates of mistreatment much more when they were already experiencing instrumental or cesarean. And people, that when I present this to clinicians, they'll say, well, you know, we were trying to save the baby, and we weren't shouting at the patient. We were, everybody, like we had to get things done. And nobody, none of us get into it to be unkind to people. And we are managing our own anxiety a lot of the times. But somebody has to remember, it's like that Monty Python film you've seen when, they've forgotten that there's a woman in the room. Like, it doesn't take that much to find someone who's that birthing person to explain what's going down and get consent. It takes 10 seconds, maybe 30 seconds if you have to explain why. And you don't also have to get consent, because sometimes people know more about their babies and maybe I shouldn't say sometimes, usually people know what's happening with their bodies. They have, women in 40 years, when we have something happening that's worrisome about the baby, it's usually the person who tells me that first. It's part of their body. It's part of their lived experience. When they decline care, 50%, this happens again and again. People will decline. And maybe it's something like an antibiotic, or it's, they don't want an immunization, or they don't want something for their baby. Lots of people. And it doesn't matter if you're, whatever race or whatever, people want that autonomy. But when they decline, who's listening? We find that with women of color, we're 2 times more likely to have the procedure performed anyway. In Canada and in the US, we're talking about, right? People kept asking them until they agreed, or they asked a midwife or a doctor or a family member to convince them. And it looks like this. The most common threat that is given is something bad will happen to you or your baby if you don't do what I recommend, because I certainly know better than you do. At my most recent birth, I had a nurse tell me when I said I wanted to go home and come back and try the induction the next day. So this is somebody who's not even declining the induction. She just wants a day. That she had a patient do that, and the baby was stillborn. She did this when I was alone in the room and my husband was returning with my parents. When people disagree with their providers, that is a open door towards mistreatment, apparently. The difference of opinion is always, 79% of people who had difference of opinion with their providers were mistreated, shouted at, scolded, threatened. Or it was done anyway. And why does this matter? Circling back to our mortality and morbidity, those really big outcomes that everybody worries about, even though it's quite rare in high-resource countries. We've studied that too, and we find that the most common reason for severe morbidity or mortality was delayed response to clinical warning signs, followed by ineffective care. People know when they're bleeding. They know when something's wrong, and they're not listened to. So then we said, okay, there's a lot of discussion now about race, and is it our skin, or is it our experience, our lived experience? And we know it's not just about race, it's also about disability, it's about being poor, it's about all of these other things. So we said, let's, instead of using race as the discriminator, because it's not race that makes you more, it's racism, right? And there's definitely a anathema in the healthcare field, at least, to say openly, to call a spade a spade. But there are these validated tools. This is a validated measure of experiencing discrimination. I heard, saw, or read others joking or laughing about me, treating me as if I was unfriendly, being called names, being pointed at. So when you're designing your birth spaces, are there private, are people being this sort of visually and here, even if it's happening as it shouldn't happen, do people have to be assaulted with that when they're in labor? When we do these day-to-day discrimination cores, again, and it's getting boring now, I'm sorry, but it's the same people who respond to being, minoritized for any of these, maybe they're young, but certainly if they have a disability, if they're indigenous and black, if they are poor, if they have a high BMI, if they need 2 or more social services, if they have a history of substance use or mental health treatment, they have higher scores on the discrimination index. We also have looked at trauma. There's a beautiful, out of London, the City College of London, a birth trauma scale, which also is through the voices of people. What are they saying about being up at night and having triggering memories? And what we can see is that there's a cascade to disparities in severe outcomes from starting with high discrimination, which increases the risk of these interventions, and then the interventions are associated with increased odds of postpartum bleeding, and postpartum bleeding associated with PTSD. So this is just one pathway, but there are these pathways where it connects. That we can say that there's a significant association between delays in care to all of these, what they call hard outcomes. Have you heard that? Hard outcomes, so things that matter. Well, guess what? It's all connected. It's that helix, right? And we also know that it increases if you have more than one. So you might not just be poor. You may also, be of color. You may be queer or trans. You may have a disability. And you can see that it increases the more intersecting characteristics you have. So we wanted to see if the participants' responses differed by birth setting. And it does, as you can see from this, we group the participants into 2 groups, hospital births and community births, and we do an intention to treat model. It's very important to me as a birthplace that if you start at home and you transfer to the hospital, you are kept in the planned home birth cohort, right? So this says that even if you start at home and you go to the hospital, you're more likely to say you have less physical privacy being violated. I would have preferred a more private and intimate birth experience, but given that he was premature, there was a need for multiple health professionals to be in the room. Just not sure why they were at the foot of the bed instead of being behind me. The males being in there made me uncomfortable, though I did not say anything. So this one, it's a longer quote. She ends up blaming herself for, in this situation, not speaking up. Can we all not look at how we set up the room so that that doesn't have to happen to the person? My physical privacy was violated, and this is disaggregated by both the provider and whether or not you're Indigenous and people of color. It's a Canadian study. It's so important for us to look at this anywhere where there are Indigenous populations. But again, I would have had the nurses keep me covered when it wasn't necessary for me to be uncovered. We had several labor complications, and there were a lot of strangers in the room. Same thing, right? I absolutely hated to be exposed like that to everyone in the room. That's a different person. We actually can create a whole poem out of all of these things. We've got so many responses. So now I'm going to go through very quickly what we found specifically to your space. So these are just, descriptive results. We haven't done complex analysis around this, really, except around, just so I could do this today, that there are these same connections with those populations. So you can see here that curtains, partitions, and other measures to protect privacy. Obviously, in the community birth, it's not really relevant unless you were talking about a birth center. I had to share a room with another mother and her baby after delivering. Although we were separated by a curtain, there was no privacy for discussions with care providers, as we could hear each other. And again, they'll say, I had to discuss it in a place that wasn't provided. And it's more, again, for people of color and for Indigenous people. We asked the question, what's one thing you would change? And that was the last question on this very long survey. And we got 2,749 responses to that. People had so many good ideas for us. And some of them said, change nothing, because they also told us about what worked. But some of these quotes that I'm going to show you now, and I know we may be over time, and I apologize for that, having started, but one thing I would change, my birth experience at the hospital, there were not enough resources in the labor and delivery ward, and it felt public. It worried me that the other ladies in the ward were dealing with their own birth stories, whatever they may have looked at, and it bothered me how my labor was affecting them. It was almost 5 years ago, and it still bothers me. I was not able to be admitted to the facility of my choice because it did not have enough beds or enough staff. My spouse could not stay overnight as there was no room for him or chair in our semi-private room. It was too small, and there was already another mom and dad baby in there. So my husband went home, and I had a challenging night, caring for my baby alone after surgery. The birth setting where I gave birth was adequately clean. For the most part, the answer was yes. And these are the people who said no. And again, it's more people who are racialized and more in hospital birth. The hospital, clinic, or healthcare provider's office was accessible given my needs. And accessibility can mean a lot of things to a lot. You know about that, right? So did they have the kind of birth tools to support physiologic birth? Did they have a water? There's this beautiful display about water that was yesterday. And could they access water? Or was the room actually accessible for somebody who was in a wheelchair, right? So our hospital doesn't have a birth center tubs that could be utilized. A birth center would have made the overall experience much better. And my own shower and tub, because she knows what's there and it feels private. And I needed to waddle across the hallway to shower after birth. The bed I was placed in during my delivery was broken. The metal slot where my foot was placed was broken and would slide down every time I used it to push. Therefore, my partner nurse alternated taking turns holding my legs for 3 hours in this position. The room I was in allowed me to get enough peace and rest after birth. Does that look like a restful place? Now, these are very, very significant. We did a little bit of significance testing this week, my team did. 31% of Indigenous service users said this is what they experienced. People of color also, where the average was 21% across the country for all populations. And hospital birth and community birth, look at the differences. 23%, community birth 1%. I gave birth around 4 a.m. and was brought to a room around 6 a.m. There were 4 of us in that tiny room. The lights were off when we got there. We asked for a chair for my husband, and they forgot, so he had to go find one. And they didn't have a stand for my IV. We just had to put the bag on the table. It took hours before my husband was able to find someone to actually get a stand. It was just a bad experience, and I was crying on day 2 because I wanted to go home. This is about water. I was able to have a bath or shower if I wanted. Again, 68% of Indigenous people said they could, was yes, but 74% across the, and we intentionally do not compare black to white because we're trying not to say white is the gold standard. So that's why you see Indigenous people, but it should be obvious to you. It's a Canadian study, right? Our hospital, again, doesn't have, I guess you've seen this one. And then moving around freely, again, I was encouraged to move around freely. Indigenous people, 41% of people said no. People of color, 33% said no. And again, a big difference between hospital and home. After giving birth, I was told to clean up after my own blood, urine, feces, or amniotic fluid. And the quantitative data says it's 3% of the, and there's still 2%. I mean, to me, that's like, it should be 0, right? Maybe you may say, 2%, that's small, 3%, that's small. But when you're talking about 6,000 responses, that's a lot of numbers, right? And not acceptable, totally not acceptable. I was in a private room, but in the same ward as other newborn babies, and these are people who have had losses. And we had so many of these people write in and say that that was so traumatizing for them. The hospital gave us a private room so we could have privacy and try to limit our contact with other parents and babies. Unfortunately, there was a vent in the ceiling above the bed that our baby was lying in, and we could hear living newborns crying. That was haunting. I would have loved to have had a soundproof room. I would have preferred a private room following my delivery. It was traumatic and unrelaxing to be alone in a ward room without my baby when there were parents and their newborns surrounding me and hearing babies cry. And this was somebody who didn't have a loss, but just had a preterm baby that was in the NICU. So I'm going to try and wrap up and give you something to be hopeful about. What I'm saying is that these environments and these experiences have huge impacts, right? It's loss of culture, it's loss of a familiar environment, it's loss of family support, privacy, dignity, autonomy and respect, and that turns into a loss of confidence in birth. So that is then multi-generational. What do they tell their daughters and their sisters and their neighbors? And is there then a reduction in self-care and efficacy and psychosocial endpoints? So what you're all doing is so important. It's not just about a beautiful architectural space, right? This is foundational to the way we start life. And what have we learned about how to enhance cultural safety in perinatal care? I will tell you just a little bit about what we've learned. You're going to hear more about that, this conference that I heard this morning, also about how we can learn from Indigenous communities who have not been influenced by the Western and dominant way of doing things in the whole world. I call it Western, but when I go to India now, I see that they've adopted a lot of the things that are not helpful from mostly the US, but from Europe as well, England. We, in our studies, have found that cultural safety can reduce mistreatment and disrespect. If you have a healthcare provider that shares your ethnicity, culture, and heritage, you have significantly lower rates of mistreatment and lower disrespect. We know that place of birth matters and that you can reduce mistreatment and disrespect depending on where you are. People who gave birth in homes and birth centers, 64% lower mistreatment, 75% lower disrespect. And when we asked the person, said, what's one thing you would change? And this is all she wrote: give birth at home, not in a hospital where there are more labor, or I will never go back to the hospital. We had so many of those. So clients have been saying this forever, right? That control environment, the process of care, their freedom to move, all of that, their family involvement, having who they want there, that's all important. So the spaces need to accommodate that. Often in hospitals they say, well, we only have room for one support person. And that's really not the way it's done in India or in Indigenous communities and many communities around the world. We ask those questions around cultural safety and family, and we can measure it, and we can say, do we have it? We can be accountable. We can help people connect with culture-centered care, and if there isn't somebody of their nation, I'll just go through this so I can. But the bottom line is that if people have access to their preferred provider in their preferred place of birth, in the way they want to give birth, their autonomy and respect scores they're like the highest there are in the whole population. So what's the action imperative then? Many of you have already read things about physiology. There are lots of publications that talk about how we enhance physiology. We know we're closer to mammals as humans, and we know a lot about how mammals give birth, about heat, what onset of labor is, how long labor is, and what helps with endurance, and what stops labor when you're being watched. That's true for elephants, it's true for us. We also know about that fetal and the newborn transition and how important that golden hour is. You all know I don't have to go through the evidence. The evidence has been there for decades about how we promote comfort and progress, how these things can help. You know, what are the physiologic advantages to upright birth? Do we have spaces that support that, and things in the room that help people be upright, or do they have to hold each other? Which sometimes is okay too. And what are those disruptive factors? What are those, as you go through these next 3 days, can you think about, do what we're designing and thinking about, attend to those things like, are there clocks? If you ever go in a labor and delivery room, I don't know if it's ever, but all the labor and delivery rooms I've been in lots of countries, have the clock on the wall right across from where the woman is staring at. Not above her head where the providers might be looking, but it's the woman watching the hours going through. We know that these things matter also in the brain. We actually have done MRIs to show that when people are in their undisturbed birth space, all the brain activity is in their creative right brain space. And the moment we start talking to them and they have to make decisions in the middle of the labor, it pulls all that brain activity to their left. You know, we know there's of course, it's not just left, right brain. There are connections between the two, and they affect each other. So from a health policy perspective, we're thinking about optimal outcomes, optimal use of technology, optimal allocation of resources, and I would say optimal birth space, and that turns into cost effectiveness. But what it would be like if everyone could have a birth like this is the family are the two women, and they had a known beloved sperm donor, and they chose to be at home because they didn't want the nurse to hand the baby to the sperm donor as opposed to the other parent. You know, if we could have undisturbed birth and people could just receive their babies this way, you know, then you come into joy, right? Joy for families, joys for babies. And then everyone has restful care. So I'm going to leave you with some sort of a charge. What can designers and architects do? I think what you're doing already is amazing from what I've seen and what I've read, but I want you to consider the impact of identity on birth spaces. You know, what are we doing for these marginalized populations? When you get it right for them, we get it right for everybody. How do we attend to cultural safety? And who should be informing birth space design? Do you have people on your teams who are from those newcomers to whatever country you're in, the immigrant? Will those birth spaces speak to them? Or do they have to acculturate and accommodate and assimilate to your culture to make it feel like that's a safe space for them? I went recently to New Zealand, and I visited a birth space for the Pacifica. It was a birth center that was specifically for the Pacifica immigrant population to New Zealand. And there were beautiful murals on the wall about the history of how the Pacifica had come to New Zealand. The food was all the Pacifica food that was served to them in a kitchen that had the kind of cooking implements that was specific to them. And the providers were all Pacifica as well. It makes a huge difference, and it can be done wherever we are. So think about family roles and who should be there, who the primary support persons are, not just is. There's food rules and customs, ceremony? Is there space for, many places you go, the indigenous people can't do ceremony that includes fire, or Indian. We use fire and Agni a lot too, because it's, not safe because the fire alarm will go out and stuff. What about those customs related to dress and modesty and privacy? Are we insisting that people take their hijab off, because they can't hear, or they need, the spaces and the things that we put on them have to be put underneath? What about those traditions, and how do we communicate with that people so that they, in a way that they can hear when they're in that right brain space? And then the second charge I have for you is, you all have been talking about midwifery, and you say midwives are leading the way. What are you doing to create those enabling environments for midwifery practice? A dear colleague of mine, Dr. Mimi Niles, talks about Kairos care, and she says midwives work, so there's Chronos time and there's Kairos time. Chronos time is the clock, right? As I said, the clock on the wall, the time limits for how long your labor should be, that it's shift changes, that is controlling birth all over the world. But Kairos time is the passage of time, the unfolding of time. How are we being with people? Do the spaces allow us to go in that ebb and flow that labor does? And can midwives do that continuity in a way that they can be fed and that they can be supported and they can rest and they can have, so that they can continue to provide that Kairos care? We can learn from Indigenous communities from around the world. We work here in Canada with the National Council of Indigenous Midwives. They have a whole toolkit on how Aboriginal midwives are with people. And finally, there's more I can say about immigrant and what you can do, but I'll just leave you with what I learned in New Zealand just recently, and they have this term called mokopuna, which is the grandparent, the elders. Mokopuna is the grandchild, actually. And so when we're thinking about the next generations, this is my mokopuna, and we involve them in all of our lives in learning how to cut. I'm making drumstick sambar there, and Fiona is, of course, engaging in that. We have these traditions around, ceremony, birthdays, blessings. We teach them about their connection to why do I wear like this? And I have to tell you that I chose this sari today for you because this is a recently made sari. So many of my saris are passed down from generations and they all have a story behind them. But this, my daughters brought me. And it is a very traditional pattern. And, just as you're doing very modern and using, materials and things that are very modern, but you're doing it in a field that is very ancient, right? And so that's what these artisans have done. This sari, this is the snake skin, and these are the wheat fields. They just looked around them when they were weaving saris, and they got patterns and materials and designs that were from their environment. And so I think we can do that also, right? We can look, I saw on your, we can bring the outside in, and we can honor those. It's in New Zealand, the Maori people call it, and that's true for us too, being grounded in our, I grew up in North America, but I didn't just dress like this for today. I wear our traditional, I identify as an Indian even though I live in North America, right? And I bring those, and my children are biracial, but they love to wear saris and have those traditions, and those are so important in these moments of birth. So that's what I'll leave you with. Thank you.